Okay, lovely. Thank you. Well, thank you very much, Anna. I should start by saying that this seminar series and the associated research project and doctoral studentship come as part of both a kind of dream and a nightmare that have combined, really. And over recent years, there has been increasing evidence.
Just as sorry to interrupt, but could you just stop your video and start it again? It's not.
Yes, of course. It's
there we go. It's perfect now.
Oh, okay.
Yep.
That spontaneously happened before I'd started and stopped it. Is that better, Mahir?
Yes, it is.
Thank you.
Sorry to interrupt.
So, no, that's fine. As many people will be aware, there has been a growing increase in the subject of public mental health. And that has led to two things. Firstly, it has led to an increasing focus on the topic of prevention and how this can be applied in a way that makes quite a lot of sense in physical mental health, although it is fair to say it's taken quite a long time for it to make sense in physical mental health, and how we can apply that to mental health. And secondly, and more importantly for me, as someone who has spent most of my time thinking in the space that typically gets thought of as serious mental ill health, and trying to encourage us away from simply thinking of that in a classic biomedical approach. On the one hand, initially, public mental health feels very much more attractive as a space to be in, but it's also very problematic to simply transfer our thinking around what gets called serious mental ill health and place it in a public mental health context. And when I am faced with challenges like this, what I like to do and how I like to approach it is to really just encourage a conversation and to start to unpick what it is that either excites or annoys me and other people about this developing initiative that we call public mental health. And I am hugely indebted to Sarah Stewart Brown in this endeavor, and I have a horrible feeling that she may actually be in the seminar. And so I'm going to tread very carefully and hope that she will be kind and compassionate in her any kind of critique of my critique of public mental health as we go along. But the
David,
public mental...
just before you move on, can you try your video? There we go. Thank you.
Is it continuing to be problematic?
It seems like it. If it stops again, I won't interrupt, but right now,
okay. And classically in public health, there are a number of key pillars that we rely on. And one of the challenges we have in public mental health is that not all of these pillars that are well established and work well in public health transfer neatly and easily into mental health. So I'll start by just naming and framing these key elements of public mental health, and then try and look at some of the challenges in transferring these into the more severe mental illness space. I should also caveat this by saying that I am not naturally comfortable using phrases like serious mental ill health or severe and enduring mental illness, because it is not my natural way of thinking about these things. But at the same time, I recognize that it is some people's way of thinking about these things and framing these things. And the important part of developing a public mental health approach to this area is that I don't want it to exclude people just because of their choice of language. So I am naturally using language that I'm sometimes very comfortable with and sometimes less comfortable with. And that will probably show in my tone of voice. But this really is genuinely about trying to unpick some of the challenges. And one of the reasons why today's topic is personality disorder as a starting point is because it's one of those areas that does get put into the pot of severe and enduring or serious mental ill health, but there isn't a classic orthodoxy about how it should be treated. So our hope in starting with this is that we start with something that on the one hand feels very difficult and challenging as something to develop a public mental health approach to. But on the other hand, we don't have a huge amount of a job to do in dismantling an existing orthodoxy. And I think one of the challenges in a lot of areas of severe enduring mental ill health is that there are strongly held views and there are orthodoxies which just don't fit particularly well with a public mental health approach. And so by starting with personality disorder, I hope that we can sidestep some of that dismantling job and just focus on the tricky business of building what we might mean by a public mental health approach. So the four key components that are often thought about in public mental health, in public health rather, are health promotion, disease prevention, health protection, and healthcare quality. And instantly, I can see why it is not a straightforward process to move from that classic approach to public health to an analogous public mental health. And I think my starting point with these difficulties is the one that certainly we have been confronted by most frequently at the Mental Health Foundation when we have talked about public mental health, and that's this concept of disease prevention. And I think there are in mental health there are two really distinct challenges around that. But first is just the notion of disease. And classically in public health, we really do know what we mean when we talk about disease. And most of the issues that public health has tried to address are reliable, valid, identifiable diseases that have a kind of coherence as a condition. And that just really often isn't the case in mental health, whether that is, and I think it's particularly not the case in things that get called severe and enduring mental ill health. And in this respect, I'm thinking very much of personality disorder, a diagnosis that when I was going through the mental health system in my teens and early 20s, we referred to as psychiatric sacking or the dustbin diagnosis, the place you went when people had given up thinking of what it is that was up with you. And I think that makes a disease prevention model quite difficult. It becomes tricky again when we think about things like psychosis, and in a later seminar we will come back and talk about psychosis in much more detail. But again, it is not a straightforward, simple disease, illness or condition that matches that lovely public health model that we like to work with. And the second thing that makes that kind of disease model difficult is something that is certainly not unique to mental health, but is one of those things that has created problems in public health, and that's the stigma associated with diagnosis. And we do see that in other conditions. And a very good friend of mine worked very hard in mental health, in health promotion around HIV and AIDS, and the stigma associated with HIV and AIDS was a huge barrier to good public health initiatives. So there are places where the learning, even from the disease model, can be helpful. And then when it comes to prevention, we need to routinely remind ourselves that prevention is commonly thought of in three ways. There's a primary prevention, which is about preventing the appearance of a disease. There is secondary prevention, which is about reversing a condition, and there is tertiary prevention, which is about mitigating the impact of a condition. And even where we may not necessarily adopt wholesale a disease model for, say, personality disorder, we should still be able to think about what things like secondary and tertiary prevention might mean in that. And I would argue, certainly in the case of thinking about things like psychologically informed environments and trauma-informed approaches, that you could even start to think about primary prevention in this space. But it does need thinking about in an open and flexible way when we start using the language of disease and disorder, because what we don't want to do, and particularly what I don't want to do, is exclude people or turn people off from engaging in this discussion because they don't buy into a simple biological model, which indeed I don't. So that's the disease prevention thing, I think, is particularly problematic. In terms of the health promotion, one of the nice things about health promotion as a public health approach is it does tend to focus on the positive. It does tend to focus on things that are strengths and values within people. And again, this is something where I think there is a natural ability to start thinking about what health promotion might mean for people with diagnoses or conditions that are seen as more serious, and in the context of today, in personality disorders. This whole area of health promotion is something where we have started to do some work, and in my 3-year stint doing a part-time secondment at Public Health England, what became clear is that there was a real appetite for health promotion in mental health promotion, but it seemed to be very comfortable in talking about anxiety, stress, mood, and possibly even sleep. But it found it much more difficult to talk about what health promotion looked like as we moved into those things that were seen as much more problematic in mental ill health terms. So Public Health England was very comfortable and creative and successful in taking a health promotion approach to low mood bordering on depression, to anxiety bordering on clinical anxiety, and sleep, which I think is a really important mental health topic. But it stopped short and didn't really know how to move into the kind of space that we're talking about today. And that is precisely why I wanted to address this with this seminar series and this particular research project. The two other key pillars of of public health. Health protection and healthcare quality. Well, healthcare quality is something that we are familiar with, and Ray has already touched on this in terms of how we look at our mental health services and how we think of those, start to think of those much more holistically, and think of those much, move away from this kind of old-fashioned model of institutional care and treating disorders into how do we support people to live the lives that they want to in the context of either living with a condition or living with a diagnosis, depending on how you choose to frame this. And I think in terms of health protection, this is where we really need to start to understand the social determinants in mental health. And a lot of work has been done around the social determinants in mental health, but where we are genuinely struggling is with the complicated nature of interplay between causation and correlation. So we know that there is a strong correlation between social deprivation and incidence of severe and enduring mental ill health. We know that there are correlations across lines of ethnicity. We know there are correlations by postcode. We know there are correlations by whole ranges of things, but untangling those into actionable causal links is much more difficult. Now, there are some things that just leap out as being straightforward health protection approaches that should work very well with severe and enduring mental ill health, and they are certainly those that might focus on minimizing trauma. I remember once having a conversation with a head teacher about how they could turn their school into a genuinely mentally healthy place to be. And I said, well, probably I think that the simplest thing you could do would be to have a really good and effective response to bullying in your school. And that's where this head teacher and I, our discussions came to a rapid halt, because she said, there is no bullying in this school. And I think that's when it becomes, that's when you cease having a dialogue. But my point in raising that as an issue is that in a sense, it doesn't matter too much whether there is a very strong causal link between bullying and personality disorder, but an effective interventions that reduce the amount and impact of bullying are just going to be genuinely beneficial. So you have to kind of, at some points, you have to take a little bit of a pragmatic approach with this business of correlation and causation. I think I am now coming towards the end of my time. I wonder if someone can prompt me for time, because I've just lost track of my clock. I think if we are happy to do so, I will bring it to a close. Bring my presentation to a close now. Thank you.